Thanks, Dr. Glee. Okay, so the objectives of today's talk are to review ureteric functional physiology and the impact of obstruction. And the impact of obstruction on ureteric contractile properties, as well as to review the impact of obstruction on ureteric hemodynamics, pressure profiles, and then to discuss the functional recovery of the obstructed ureter. And then finally, Dr. Lange is going to teach us about research into pharmacological interventions to accelerate the functional recovery of the ureter after that obstruction is removed. So ureteric obstruction affects both the pediatric and adult populations, and it can result in permanent renal damage. The degree of renal injury depends on the severity of the obstruction, chronicity, the patient's baseline renal function, and the presence of other mitigating factors such as a urinary tract infection. And this results in multiple histologic and functional derangements in ureteric physiology. Causes of ureteric obstruction, there are many, generally grouped into 4 different categories. The first being congenital, such as a ureterocele or obstructing megaureter. The second being neoplastic from a urothelial carcinoma or metastases. And then we have inflammatory processes like an abscess, ureteritis cystica, endometriosis, TB. And finally, the miscellaneous category, trauma, stones, pregnancy, RPF, to name a few. The clinical presentation of ureteric obstruction is that classic flank pain radiating down to the groin, even into the labia or testicles, associated with nausea or vomiting due to distension of the renal pelvis and activation of the visceral nerves. Whereas chronic ureteric obstruction can be even asymptomatic or silent, so there's quite a range, and it has to do with the function and the response of it to obstruction. So contractile physiology. So the function of the ureter is to provide a conduit for urine from the renal pelvis down into the bladder. And Griffiths described the mechanics of urinary transport, which is schematically represented here and still represents how we think of it today. So at normal flow rates, the renal pelvis fills and there's a rise in renal pelvic pressure. This then pushes the urine into the proximal ureter, which is initially in a collapsed state. And then it triggers a contraction wave originating in the most proximal portion of the ureter, moving the urine down to the bladder as a bolus. To propel the bolus efficiently, the ureteric walls have to completely coapt in order to generate the pressure to push the urine down. And inadequate transport results from either too much fluid entering the ureter or too little fluid leaving, such as in the case of obstruction. And this results in dilation and inefficient transport. So to look more at the functional changes, this is a study by Weiss, which measured interluminal pressure and diameter changes after complete obstruction of a rabbit ureter. So on the x-axis, you could see the time, initially in hours, and then leading up to 8 days, which is when they stopped their experiment. And the y-axis are those 2 parameters, diameter and pressure, over their original non-obstructed values. So as we can see on the bottom graph, the interluminal pressure rises sharply and peaks at the 3-hour mark, and then slowly declines and stays at a plateau, whereas the diameter of the ureter in the top graph continues to increase as the ureter dilates and hydroureter develops. They also noted a transient increase in the amplitude and frequency of peristaltic contractions, which then became smaller until the ureteric walls could not completely coapt. And at that point, the urine transport was now dependent simply on hydrostatic pressure from the kidney. So overall, at 8 days, the diameter increased by 170% and the length by 25%. Moving on to the contractile properties, I wanted to look more closely at the mechanical compensatory mechanisms of the ureter in response to obstruction. So Hansman again used a rabbit model, obstructed a ureter completely for 2 weeks, And after 2 weeks, they found the cross-sectional area of the muscle increased by 250%, the ureteral length increased by 24%, and the outer diameter increased by 100%. They then performed in vitro force length studies, which are represented here by the graphs. So the control ureter is blue, that's the non-obstructed, then the obstructed ureter is in pink. And they found that these in vitro segments from the obstructed ureters could generate greater contractile forces in both the longitudinal and cross-sectional and circumferential directions than the control ureters. So this left me with 2 questions. One was, is the increased force generation due to simply the increase in muscle mass that we see in the ureter, or is there an actual change in their contractile properties? And then 2, how do we explain the decreased peristaltic efficiency of the obstructed ureter when it appears to be physically stronger? So to answer this, I found a study that looked at the physical parameter of stress, again in rabbit ureters in an animal model, who were completely obstructed for 2 weeks. Stress is the force per unit area of muscle, so this will help to delineate whether those changes are due to size of the muscle or the actual fibers themselves. So again, control ureters are blue and the obstructed ureters are in pink. And the graph on the left looks at the longitudinal force-length relationships, as well as cross-sectional area and stress. And then the graph on the right is the same parameters, but in the circumferential direction. So comparing the stress results, the longitudinal stress is the same between the control and obstructed ureters, but the active circumferential stress generated by the obstructed ureter is actually significantly greater than the control. So for these differences to exist, it means that there has to be rotation of the muscle fibers, or else both stress measurements would have increased equally. And this is likely due to ureteric dilation, which I'll talk more about. So a dilated ureter after 2 weeks is not mechanically decompensated, but rather undergoes changes that increase its contractility, muscle hypertrophy, making it stronger. But we know that a dilated ureter isn't as efficient as a normal ureter at generating those contractile pressures to efficiently move the urine down into the bladder. So why is this so? It all comes down to the Laplace equation. So the decrease in intraluminal pressure, despite an increase in contractility, is due to the overwhelming increase in ureteral diameter, hydroureter, that occurs after obstruction. So there's an overall decrease in the wall thickness to radius ratio, and this then accounts for the decrease in pressure generation by the ureter. But the ureter isn't just a muscular conduit that transports urine. Its pressure and function also depends on urine production and kidney blood flow and hemodynamics. So we found that differences do exist in those parameters between unilateral ureteric obstruction and bilateral. So to look first at unilateral obstruction, animal experiments have demonstrated a triphasic pattern of renal blood flow and ureteral pressure changes during unilateral obstruction. This is demonstrated here. This is a study actually done in 1975 by Moody, which has stood the test of time and is still referenced in physiology textbooks today because of their model of an obstructed ureter. This is in dogs. So we see these 3 phases highlighted on the left graph by the Roman numerals 1, 2, 3. So the first phase of acute obstruction in a single ureter lasts 1 to 2 hours, and there's an increase in pressure in the renal tubules of the affected kidney and a subsequent decrease in GFR. The vasculature then tries to compensate for this and releases vasodilators such as prostaglandins and nitric oxide. In phase 2, the next 3 to 4 hours, the pressures remain elevated as the obstruction is ongoing, but the blood flow then starts to decline. And this is due to increased resistance in the afferent arteriole. And then you can see in phase 3, both the ureteral pressures and the renal blood flow decline progressively, and this is what results in a loss of renal function. There's a global lack of perfusion to the glomeruli due to this increase in the afferent arteriolar resistance. So to look more at the mechanisms explaining that, initially it was thought to be due to an upregulation of the RAS system due to thromboxane A2 production, but Vaughan in 2014 did a study and found that there wasn't any significant relationship between those mediators and the renal hemodynamic response. More recently, due to work by Felsen, there's been implication of nitric oxide in the late hemodynamic responses. Nitric oxide, as we know, is a vasodilator. It's formed by the conversion of L-arginine to nitric oxide by nitric oxide synthase. And this is their work. It's the busiest slide I have, but I'll go through it here. So this is an animal model in dogs, unilateral obstruction, and time on the x-axis, and then the different parameters on the y. So left is renal blood flow, and right are the ureteral pressures. And basically, what they did is they obstructed the ureters, and then at 18 hours, they administered L-arginine and looked at the parameters. So the yellow circle group is a control group. It's an obstructed ureter that did not receive L-arginine. The black group is also a control. It's just a non-obstructed ureter that also received L-arginine. The blue group is our experimental group. Obstruct the ureter, administer L-arginine at 18 hours. And these are the changes that they found. So they actually found that the renal blood flow did increase after L-arginine was administered. And on the right graph, looking at pressures, they again found that the ureteric pressures increased after L-arginine was administered. This is presumably from formation of nitric oxide, causing dilation, and increasing the urine flow. So basically what it demonstrates overall is that it suggests a lack of availability of the substrate of L-arginine to produce nitric oxide in the late stages of unilateral ureteric obstruction, and that this may be the mechanism explaining it. So to look at bilateral ureteric obstruction, as opposed to nitric oxide, it's atrial natriuretic peptide that's been implicated, or ANP, and it has a unique role in the hemodynamic changes observed. So in bilateral obstruction, because there's no second renal unit in order to compensate for one-sided obstruction, the intravascular volume will increase in response to blocking both ureters. And this stimulates ANP release from the cardiac atrial myocytes, which then goes to the kidney and causes a sodium diuresis in order to try to decrease the intravascular volume. So the effect on the nephron is this. So with unilateral obstruction, we know nitric oxide, afferent arteriolar vasodilation in order to try to increase the filtration through the glomerulus. Atrial natriuretic peptide also causes dilation, but it also constricts the efferent arterioles. And this is to try to greatly increase the pressure, the filtration pressure inside the glomerulus in order to decrease the volume. But it's this sustained increase in pressure that occurs with bilateral obstruction that will lead to tubular dysfunction and ultimate renal function decline. And then Kim performed a study looking at this as well, and they found high plasma levels of atrial natriuretic peptide in animals with bilateral obstruction as compared to control animals or animals with just unilateral obstruction. So this is a rat model of bilateral obstruction for 24 hours. And then the obstruction was released in 2 other groups, and they measured those levels again at 4 and 24 hours later. So they looked at plasma and urine ANP levels, as well as mRNA expression of ANP. And in table 1, you can see there's a statistically significant increase in plasma ANP levels in the bilateral obstructed group. And the figure on the right is the mRNA expression, and it shows that there's significantly higher expression of ANP in rats with bilateral obstruction compared to controls, and that this persists at 4 hours, but then those levels go back to normal 24 hours after the obstruction is released. So again, confirming or providing more evidence that likely there's a cause and effect relationship here. So with that, I would like to introduce Dr. Lange, who's from the Vancouver Stone Center, who's done some amazing work in this area and was also awarded first prize as an early career investigator at the AUA. So Dr. Lange.
Thank you very much, Hilary, for the kind introduction and the opportunity to present some of our most recent work to you in this area. So, for those of you who know about the Stone Center and some of the work we've been doing, in an effort to develop novel approaches to improve the treatment of kidney stone disease, we've been focusing our efforts mostly on ureteral stent biomaterial design, but most recently we've also expanded this research program into studying and understanding how the ureter responds to indwelling stents and obstruction. Now, why focus on studying how the ureter responds to indwelling stents? Well, as you know, stents are associated with significant patient discomfort and severe pain, and that's one of the most common complications associated with stenting, in that 80% of stented patients complain about this. Some of the causes for this are known, such as the irritation of the urothelium as the stent moves inside the ureter, as well as the bladder, while others remain unknown. And those are the ones that might be associated with negative effects on ureteral function. An example of this is stent-induced hydronephrosis, as well as aperistalsis. And what we have here, I don't know if you can see that. Okay, you can't see, but in the, yeah, I'm trying, I don't know, is it showing up?
If you put it on the slide on your screen, it should show up.
Yeah, no, that's fine. That's okay. That's okay. And it's not gone. On the left graph, essentially shows the level of hydronephrosis in stented pigs. The top line represents pig ureters that are stented with a normal polymeric stent, while the bottom one is actually a ureter stented with one of the biodegradable stents that we've been working with. The point of this particular graph is to show you that despite the fact that the ureter is stented and there is no sort of obstruction in these ureters, there's still a significant increase in hydronephrosis in these particular animals. And the graph on the right-hand side shows basically that stented ureters actually become aperistaltic within 48 hours of actually stenting the pig ureter. So these are two significant issues that may contribute to some of the patient's discomfort. And so that's what led us into actually trying to understand how the stented ureter is actually functioning, or the lack thereof. And so for this, I'll go to this slide first. The big question for us was that, considering that stents are supposed to facilitate urinary flow, which they do to a certain extent, why do they stop peristalsis, which is the one thing that's supposed to drive urine flow? And specifically, what we decided to look at is what the molecular mechanisms are that actually regulate ureteral peristalsis, because once we can identify some of these molecular pathways, we might be able to develop new therapeutic agents to promote ureteral peristalsis with a stent in place and make the whole system work better. So what molecular pathway do you target? Well, we chose to start with a molecular pathway called the Hedgehog signaling pathway, which mostly functions during embryogenesis and development of many organs, including the urinary system. And why did we specifically focus on it in terms of the stented ureter? Well, as it turns out, if you inactivate Hedgehog, it actually results in hydroureter as well as hydronephrosis, which are commonly seen in the stented ureter as well. In addition, what they found was actually that this was caused due to an aperistaltic state of the ureter. So what we did was we stained ureteral sections from stented pigs that were stented anywhere between 48 hours and up to 7 weeks, and specifically looked at one of the main effector molecules of the Hedgehog pathway known as GLE1. It's a transcriptional activator that's responsible for activating all of the genes that are regulated by Hedgehog. And essentially what we found was that, as you can see in the top panel, that is an unstented ureter, you can see that the smooth GLI1 expression within the smooth muscle of the ureter is significantly higher than in the bottom panel, which is hydroureter, which is a stented ureter. So when you look at that over time, in the graph on the right-hand side, the black line represents GLI1 expression over the 7-week indwelling time of a stent. As you can see, as early as 48 hours post-stent insertion, GLI1 expression begins to significantly decrease, and it remains low up until you remove the stent at 7 weeks, and increases steadily back towards normal levels in the 3-week recovery period. The top graph actually represents inflammation of the ureter. So essentially what you can see there is that as inflammation of the stented ureter increases, the expression of GLI1 decreases. But what are the functional consequences of this? And so what we did here was we actually stented a separate group of pigs for 48 hours and 7 days, and we actually looked at the smooth muscle activity in tissue baths by basically measuring the amount of force that's generated by the smooth muscle in stented and unstented ureters. And essentially what we found was that as the diameter, and this is the graph on the left-hand side, as the diameter of the ureter increases due to the stent dilating the ureter, the force per smooth muscle area actually decreases significantly, suggesting that smooth muscle activity becomes dysfunctional as the stent remains indwelling. And the graph on the right actually shows that the time to peak forces are also significantly increased in stented ureters compared to non-stented ureters, again indicating that there is smooth muscle dysfunction as a result of stenting. So just to summarize that, again, indwelling stents dilate the ureter, which is desirable. However, what actually occurs is that as that ureter dilates, it stretches the ureteral smooth muscle, resulting in overall dysfunction and an aperistaltic state, which is undesirable, because decreased peristalsis means lower urine flow and increased reflux, resulting in the hydronephrosis that we see with in the stented ureter. So again, the question is, can we target molecular pathways such as the Hedgehog pathway to maintain peristalsis with a stent in place, because that could potentially result in improved urine flow and less patient discomfort with a stent in place. So this led to another question, which is, how does the ureter respond to a complete ureteral obstruction? The stented ureter, if you think about it, it represents a partially obstructed ureter. And we already know that, and Hilary already presented this as well, that complete obstruction of the ureter results in disruption of peristalsis, decreases and completely stops urine flow from the kidney to the bladder, increasing the pressure, resulting in hydroureteronephrosis, and of course, if that remains untreated, you get renal injury, dysfunction, and eventual renal failure. So the common research focus out there is basically to look at the effect of ureteral obstruction on kidney function. But we kind of decided to take a different spin on this and try and look at how does the ureter actually respond to obstruction. Nobody's really ever looked at this, and also how does it recover from obstruction. The common belief is that once the obstruction is reversed and hydronephrosis goes down, everything is back to normal. So to do this, we actually performed unilateral ureteral obstruction in mice. We've seen several studies earlier looking at larger animals. Anybody can obstruct a ureter in a larger animal. We decided to take on the challenge and do it in a mouse. So what we did was we obstructed the ureters using traumatic vascular clamps for 24 hours, 48 hours, and 72 hours. Followed hydronephrosis via ultrasound, and also quantified the peristalsis visually pre and post obstruction reversal. And if you look at the graph on the top right, that shows, once again, as we saw in the pigs as well, that as the diameter of the ureter and the level of hydronephrosis increases, the peristaltic activity significantly decreases. Now, what happens once you reverse that obstruction? And the graph on the bottom left shows exactly that. The bars on the left-hand side indicate all of the three different groups, again, the 24-hour, 48-hour, and 72-hour obstructed animals. Pre-obstruction, you can clearly see that peristaltic activity is quite high. And then the bar graphs, the bars on the right represent peristaltic activity the day that hydronephrosis has resolved. And you can see that peristaltic activity is still significantly decreased. The graph on the bottom right basically shows how long it takes for peristalsis to actually recover towards normal level after hydronephrosis has resolved. If you look at the graph there, hydronephrosis has resolved at day 2, and it takes an additional 9 to 10 days for the peristaltic activity of the ureters to actually return to normal. So what does that mean? Well, it refutes the hypothesis that resolution of hydronephrosis means there's normal ureteral function. This also suggests that ureteral dysfunction remains, meaning that there is still potential decrease in urine flow, meaning that there might be potentially prolonged negative effects on kidney function. The question we asked, can we accelerate recovery following obstruction reversal? So for this, we turn to erythropoietin. Why EPO? Well, it's been shown to work with Lance Armstrong, of course, but it's also been shown to have protective effects in other organs, such as the brain, even bone, the heart, and as well as the kidney in response to hypoxic conditions. But more relevant to our case, there is a study that has shown EPO to actually restore bowel damage and hyperperistalsis in the injured intestine. And the significance there is that intestinal peristalsis is believed to function similarly to ureteral peristalsis. So what did we do? We basically performed the obstruction experiments again, but this time gave 20 international units of EPO to mice on 4 consecutive days pre-obstruction. Now, why pre-obstruction? Generally, that's how the experiments are done, looking at the effects of EPO to see how it functions if you give it prophylactically, essentially. And again, we followed recovery using ultrasound and quantified peristalsis. And as you can see quite clearly by the ultrasound pictures, the top panel are the control animals that did not receive EPO, whereas the bottom panel are the animals that received EPO, and you can quite clearly see that hydronephrosis resolves much faster in the EPO-treated animals. And again, on the graphs on the right represent the different animals in terms of 24-hour, 48-hour, and 72-hour obstruction. And again, you can quite clearly see in those graphs that the level of hydronephrosis is decreased in the EPO-treated animals. Now, what about accelerating recovery? Well, similar results were found here, where EPO was actually found to accelerate the recovery of ureteral function in all 3 groups, where again on the graphs you can see that peristaltic activity recovers much quicker in the treated animals versus the untreated animals. So what does this all mean? Of course, the companies that make EPO will get all excited about this sort of thing, right? But the intention of this research is not to promote the use of EPO for patients with obstruction. Of course, as you know, there's significant side effects profiles associated with it, and it's also very expensive to use. The intention of using and studying EPO is to basically learn what molecular mechanisms are activated by it, because once we understand that, we can again identify potential targets for novel therapeutic agents that will be less expensive, safer, and much more effective in the future. So what are we doing currently? Well, current studies in the lab are aimed at actually understanding molecular mechanisms regulating that ureteral dysfunction following obstruction. And for that, we are focusing on some of the members of the Hedgehog pathway, because there is actually a link between erythropoietin-induced signaling and Hedgehog activation. And how these, of course, are changed by EPO. What I can tell you, we do have some very, very preliminary data that seems to suggest that there is an effect on Hedgehog effector molecule expression, so which is somewhat exciting, but again, that's very, very preliminary. In addition, we are also currently working on obtaining ethics for human ureteral tissue from transplant donors. Of course, that will be tissue that would not be used as part of the transplant, to basically try and understand how EPO treatment would affect peristalsis using tissue baths. And I have the ability to test, to use these tissue baths through a collaboration with Chan Seo at St. Paul's Hospital. So with that, I hope that you've gotten a bit of an insight into some of the research we're doing into ureteral obstruction at the Stone Center. And I'll open it up to questions for Hilary and myself. Thank you.